Hi, this is Dr. Gogas, editor of USC Journal, and today I have the pleasure to have with me a very special guest, Professor Tanveer Rab from Emory University in Atlanta, Georgia. He's professor of interventional cardiology, a mentor to all of us, to many of us. He's a very well-known complex operator and also very well published. Professor Rab is here with us today to speak about the two stenting technique in complex bifurcations, about the double kissing crash with two exceptional cases. Dr. Rab, thank you so much for being with us today.
Good morning. Thank you very much, Bill, for inviting me to this program. You're doing a great job with US Cardiology Review, and there's a lot of momentum to build that up. But thank you for inviting me. So I'm going to present two cases, very complicated cases, and they could have been tackled in many different ways. So I'm going to start with the first case of an LED diagonal DK crush procedure. So this was a 40-year-old male from Finland who was happening to be traveling through Atlanta for his job. And he presented to the emergency room with chest pain and the following electrocardiogram, which showed Wellens wave in the anterior leads, possibly a small Q in V1. And he had a positive troponin, I believe it was up in the 20-30 range. Now, his had a very strong family history of coronary disease. He was a non-diabetic, non-smoker. Total cholesterol was 211, triglycerides 407, HDL 36, and the LDL could not be calculated. So we brought him to the Cath lab because he had a high-risk non-STEMI. Just looking at the EKG, you'd think of proximal to mid-LED lesion. So, but what he had was this very long, diffuse LED lesion, starting just from the origin, before the origin of the large diagonal itself had a long lesion. And the septal perforator was mildly pinched, but the main thing was this was a lesion which was more than 40 millimeters in length, the LED, and again involved the large diagonal, and there was a stenosis just proximal to the bifurcation. So clearly this was a Medina 111 lesion. So here we go, and you know, as a young man, what are the best options for this person? So this is something we need to give some thought to. Of course, he needs revascularization, be it surgical or percutaneous. So Bill, do you have any comments here?
So yeah, as far as I see here, the side branch is severely diseased, more than 90%, and we have diffuse disease. And I can see here in your slide on the right side the definition criteria that were established recently by Professor Xiaoliang Chen to differentiate simple versus complex bifurcations, and according to complexity, to use either two-stent technique, any of the two-stent techniques. So I believe here we're talking about a complex bifurcation that needs an approach with two-stent techniques.
Yes. So obviously for the definition criteria, this is a non-left main bifurcation. So the criteria of stenosis is 90%, not 70% like distal left main, but the lesion length greater than 10. I think most of us, and certainly the more recent trials and publications, you know, any lesion that's greater than 10 millimeter length, you know, becomes, you know, significant in side branch. This patient did not have any calcification. Bifurcation angle was satisfactory. Now the reference vessel diameter was about 2.5 or a little bit more than that. Main vessel lesion length is definitely more than 25. So all these, you know, add to the complexity of the lesion to think about percutaneous revascularization. But you know, in a young person, if you have the facilities, if you know, don't want to send them to a full open surgical bypass, the mid to distal LED is a good target for left internal memory artery graft. So if you have the availability of a hybrid program or robotic Lima to LED, that'd be a great option for this patient, you know, because, you know, as you know, he'll have a lot of metal in the LED. So what do you think, Bill? What are your thoughts? The patient is not a diabetic, but, you know, he had a sense of urgency of going back to Finland because Atlanta was not his home.
Right.
Issues of insurance.
Yeah.
He was young. He just wanted to travel back home. And certainly surgery was not his mind. But I mean, apart from that, I mean, he's not a diabetic, but for his long-term prognosis, isn't Lima to LED a good
Right.
choice here? And one could always come back and stent the diagonal. So
Yeah. I think most of the data, when we're looking very long-term clinical outcomes, I think the Lima graph is superior to any stenting technique. But when we're talking about very long. But now, as you say, he was a traveler. He wasn't, he needed an urgent therapy in order to go back. I think PCI should be a good alternative to that.
now his circumflex had luminal disease, and the right coronary artery didn't have much in the way of disease.
Just to interrupt you, so you continued with the radial approach, right? 6 French radial approach.
This is a radial axis case, and we
Yeah.
preloaded him with the clopidogrel in the lab and aspirin. So, but in the current era
Okay.
today, what would you do differently? Will you try one of the other agents like prasugrel or ticagrelor?
Well, yeah, I mean ticagrelor. I think in a patient that doesn't have any history of bleeding, and when I need a very fast anticoagulation, I think ticagrelor should be suitable also for this patient.
Would you consider long-term monotherapy or just adapt for 3 months and long-term ticagrelor, or just a year?
Yeah, that's a great question. Yeah, when we're having a 2-stent technique, as long as we use imaging to optimize, and we have optimal mean stent areas, I would think of monotherapy, but not after 3 months, a little bit later. But when we have 2-stent techniques, I'm more in favor of having 1 year DAPT.
So we, as I told you, right coronary didn't have much in the way of disease, and the circumflex. His LV apex was sort of mildly hyperkinetic, and EF was about 50%. LV EDP was 16. So,
yeah.
So we felt comfortable in proceeding with the radial approach, with the anticoagulant being intravenous heparin. That's what we use over here predominantly. We don't use any Cangalore, and certainly we have not used bivalirudin for a long time. So we put 2 run-through wires, and we pre-dilated the LADs before the bifurcation with the 2/30 millimeter balloon. And we also decided that we could primarily stent the diagonal. We're thinking about DK crush because clearly this is going to be a 2-stent approach. And we put a 2.5 by 26 drug-eluting stent in the diagonal with protrusion into the LAD. But the LAD is, is not the largest vessel. So you want to protrude 1 to 2 millimeter inward.
Yeah.
The balloon sitting in the LAD.
A small detail, Dr. Rab. So your balloons were non-compliant balloons for both vessels?
No, these were regular balloons. These were semi-compliant balloons.
Regular balloons.
Yeah.
Okay. And in terms of the 2-stent techniques,
I rarely use non-compliant balloons because unlike Europe, the ones available here still have a little bulk to it.
Together with DK crush, what other 2-stent techniques you might use here? A mini crush or what other 2-stent techniques are the options here?
I don't use mini crush. A T with minimal protrusion would have been reasonable after you stent the main vessel. Of course, you can use a culotte technique, but I think the newer version of double kiss culotte may have been a reasonable approach. I don't use stenting or simultaneous kissing stent. I don't think there's a role for this here because there's a lesion right before the bifurcation.
And also you said about the DK culotte. So we know for the culotte, the best approach is when we have the same reference vessel diameter for both the main branch and the side branch. This is also the same for the DK culotte. We need to have the same, more or less the same diameter of the vessels.
That's probably correct. But these are kind of small, and you don't want to put a lot of metal in the prox LED. So I think this strategy of minimal protrusion is what is most reasonable in my mind. So
minimal, you mean 2 millimeters maximum?
Yeah, 1 to 2 millimeter. But remember, the LED is also not the largest vessel here, right? I mean, now one thing I did not do.
Right.
This was done a few years ago. I think this was done about 4 years ago. As you know, since the ultimate trial came out, we're doing a lot more imaging. Certainly now I'm up to 90% imaging in all my cases.
Yeah.
It gives you, even if vessels are very small, and you may think they're not stentable, your window's open because the vessels are actually could be quite large. So if you think it's a 2 millimeter vessel, you go in, I have actually 5 vessel or larger. So imaging is so important.
Yeah.
I really become a believer in that and pretty guiding these 2 techniques.
Right. And Dr. Rab, are you in favor of IVUS or OCT or both? I mean, Ultimate was primarily IVUS based, IVUS guided PCI. It was, it was an all-comers trial. But are you in favor more of IVUS or OCT in non-left main bifurcations?
I think, I mean, IVUS is easy to use, so and you're quick about it. So I'm using a lot of IVUS. OCT obviously requires
IVUS,
special
right.
use of contrast, though. For proximal lesions, people have been using saline flushes, and they have been having quite good results. So I've seen our colleagues in Canada do that. They just use saline flush for real proximal lesions, and not worry about contrast, and they get a pretty good idea. So this is the position of positioning of the diagonal side branch stent. Remember, you must have a balloon across the parent vessel,
right?
So because otherwise you'll have real difficulty
exactly.
recrossing. Bill put these slides in, and to show that you.
So this model nicely shows that at the protrusion of the side branch stent, we need to have in place the balloon in the main vessel. Otherwise, if it's more distal, it's very difficult to put it in the proximal side. So it's very critical, as you see so here in the angio, that the main vessel balloon should be already placed at the protrusion of the side branch stent.
The only comment is that obviously this is a model. The side branch stent is too far in. It should really just be, the tip should just be touching the balloon in the main vessel. That will give you a lot around. So one of the hints you can get is that when you have the balloon sitting there or the corneal guide wire sitting there, you can have the tip marker of the stent just barely touch it, and that will give you an approximation of 1 to 2 millimeters into the vessel roughly. So this is the inflation of the diagonal stent. You take out, then you take back the balloon out, the diagonal balloon out, and some people remove the wire from the side branch, some will leave it in, but you can, but the wire will come out, okay? And then you balloon crush or the diagonal after stent balloon withdrawal. Now, there's a little difference in technique now. Some operators talk about proximal stent optimization, meaning once you deploy the diagonal stent here, you bring the balloon out and really bring it to high pressure, so the orifice is really well dilated, and then crush it, because that gives you easier recross and less metal. But that technique had not come out or talked about when I did this. But remove the balloon. Obviously, if you don't remove the balloon and you crush it, your balloon will be trapped and you get into a lot of trouble, and you may not be able to withdraw the balloon. And then you balloon crush it. I use the same semi-compliant balloon that I had. Now, some may say, well, you should size it up or size it to the diameter just before the bifurcation and use a non-compliant balloon to crush it. But in this case, I didn't do that.
Yeah, I think the proximal optimization, I mean, although there are some modeling and there are not many big studies, certain operators use it in order to enlarge the protruding struts. So then when we try to rewire and pass the balloon for the first kiss, then this facilitates the whole process. But this is subjective. It depends on the operator and his experience.
So this is what he's talking about, the proximal optimization, proximal stent optimization.
Right.
You dilate and bring back the balloon and really open it up. Okay. So that's what it looks like when it really gets. So now, I must say in this cartoon or this model, this stent is too far into the main vessel. So after that, because this was a very long lesion, I decided to stent the distal LED. Remember, it was a long lesion. Probably I told you it was more than 40, 45 millimeters. So I avoided the bifurcation altogether, but you don't want to have overlap of two layers of metal, right at the carina. That would definitely is a no-no. Increase the chance of stent thrombosis. So I placed the first stent just to the bifurcation, okay, and then I proceeded to recross back into the diagonal with the same run-through wire. It was very difficult, and then performed a first kissing balloon inflation. Okay, so this is the first kiss in a DK crush technique.
So here, Dr. Rab, is important to select the proximal cell as opposed to the distal cell. That is pretty much very frequent to all the other techniques. So of course, the proximal cell is, when we have these small vessels, it's not very easy to select it. But does imaging help in selecting the proximal cell?
Yeah, I think people who do a lot of OCT, particularly in Japan, tend to do that. But, they go back and forth in choosing a cell, and, it can become a little tedious. But I think with the new imaging systems, particularly from some of the vendors like Philips and all that, you really can see stents very clearly. And if you have stent boost, you really can tell. I don't know about the dynamic roadmap. We're just building Cath lab where I'm working. We're going to have a dynamic roadmap and also stent boost. But for all DK crushes, try to cross into the proximal cell or more close to the prime.
Yeah. Okay. So when we engage the distal cell in the strut, what are the main problems that we cause in the side branch?
You can a lot of metal at that point, right? So you can have and then you can have a retraction of the stents from the side branch. So you get a sort of sort of a lot of metal accumulating if you don't cross the proximal side branch.
So this is the first cross, the first
kissing
balloon inflation, right? Here. Yeah.
So I've rewired and I've done first kiss. And now in the first kissing balloon, there's certain things you need to know. When the balloon goes across, of course you have the balloon, the main vessel. You need to go to very high pressure with the balloon that recrosses the side branch. Then deflate it, then go to high pressure on the main vessel, deflate it. And then high pressure means above 16 or so. Then you do simultaneous
16 atmospheres.
For probably about 12 or so, and then deflate simultaneously, okay? So now you really have to remove the wire and balloon again, because once you put a stent across, you can't remove the other hardware.
Yeah.
So we had a Prox LED stent, 275/26. So basically we have added close to 54 millimeters of stents in the LED, and we overlap with the mid LED DS. You can see with the shadow of the diagonal branch that the stent now ends way beyond the bifurcation. So there's not a lot of metal there. And after you do that, you have to do a pot. So took a trio non-compliant balloon. This is the only time I use non-compliant balloons to do pot. So I took a trio to pot.
For the pot.
Pot, okay. So pot the stent.
Yeah. And you size so for the pot, you size the non-compliant balloon based on the proximal reference vessel diameter, right?
Correct. That's correct. And remember, in this case, I did not use iris, okay? This was just angiography.
Yeah.
So after this, we have to rewire. Rewiring, what are the wires that are good for rewiring? So I like to use the run through. It generally gets me back in. If that's not successful, then I'll use a Pilot 50. If that's not successful, I've gone to use the new Asahi Mongo wire, and it tends to find the stress to go back in. But this was the same run through wire, and you recross, and again you go, and again you leave the balloon, the main vessel, the LED, recross again, go to high pressure like 16, deflate, then go to high pressure main vessel 16, deflate, again do simultaneous kissing balloon inflation to 12, and then deflate simultaneously. And then you can pull the hardware out of the side branch and do a final pot with the same trio non-compliant balloons. Okay, so we have done the second kissing balloon inflation, and so it's a double kiss
and repot.
And we're going to final pot. Okay.
I just have some points to mention. Okay. The first one is that we need to classify the bifurcation, either simple or complex. And if it's complex, to select the two-stent technique. Obviously, DK Crash has shown very good data in randomized trial compared to other two-stent techniques. Also, I wrote here that you used for the pot always non-compliant balloons, which are sized based on the proximal reference vessel diameter. And also for the rewiring, your wires that you are using is you start with a run-through wire, then you go to the Pilot 50, and then if you're not successful even with that, then you're going to the Asahi Mongo. Yeah. These are great points. Yeah.
Now, there are some other rewiring strategies that you could use if you cannot get back with side branch. You can use special, gadgets like the venture.
Maybe an anchor balloon technique.
Or anchor balloon technique, or you can, supercross, 120, or you can use the you can use catheters, the dual lumen catheters that allow you to rewire.
Dual lumen catheters,
And,
I see. Yeah.
And you can use that as well. Okay. But I've really, to be honest with you, in all my years doing this, I've not really had much trouble getting back in, except in one case where it really angulated and I had to use a venture catheter. but I really have not had trouble rewiring. If you do a good job with your first side branch stent,
Yeah,
now proximal stent
exactly.
then I think recrossing the first time around is not that difficult. Of course, after you do your stent, a pot is so important, and for you to be able to get back into the side branch, a good pot will get you
Mhm.
back in.
And in terms of long-term DAPT, what did you
So we told
prescribe?
him at that time when he left, I told him to be on DAPT forever. But I think maybe now the tendency would be to keep him on long-term monotherapy if his doctor. I don't have a follow-up on him. If his doctors in Finland decided,
Yeah.
the long-term monotherapy, then I guess
Mhm.
most recent data from this week is long-term ticagrelor reduces both bleeding and ischemic risks.
And I mean, later on, we will see some data from the double kiss cross, but I think you have another case
Yeah.
that involves the left main, right?
What did you have done differently here? Of course, imaging would have been very important here, I guess, at least for the LAD. Retrospectively.
Yeah, not. I think not different, but yeah, I think retrospectively, I think the eye was to see the final mean stent area, at least at the bifurcation and the proximal segments. At the LAD, we need to have it in the range of more than 7 square millimeters. I think this is what I would add in this case, but it was perfectly done.
Interestingly, if you get reasonably good at this procedure, this particular case, because it was a young man, the vessels were not very calcified, wiring was easy. Actually, it took me less than 30 minutes to do.
Yeah.